Strains, sprains, broken bones, and joint replacement all fall under the category of orthopedic problems. And that's what we're talking about tonight on Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth. I will be your host this evening. We'll be happy to take your questions about orthopedic problems. Just give us a call. The local number is 218-788-2844 or toll free 1-877-307-8762. I'm pleased to welcome tonight's panelists, Dr. Samuel Harms, an orthopedic surgeon with Orthopedic Associates Duluth, Dr. Bradley Kuzel, an orthopedic surgeon with Essentia Health-Duluth Clinic, and Dr. David Rust, an orthopedic surgeon with St. Luke's Orthopedics and Sports Medicine. Our medical students answering the phone tonight are Mr. Michael Borner, New Prague, Minnesota, Samantha Gardine, Spooner, Wisconsin, and Linda Lotka, White Earth, Minnesota. And now on to tonight's program, Orthopedic Problems and Joint Replacement. Gentlemen, good evening. It's great to have three orthopedic surgeons here tonight.
Thank you.
I think it would be good for the viewing public to have some idea, a little bit of what you go through in training. So I think, Dr. Harms, I'd like to start with you and just ask you, what is an orthopedic surgeon? And can you give us a little background?
Sure, absolutely. It is, orthopedics is a certain specialty within medicine. Just like your medical students in a couple of years, they'll be deciding what specialty they want to go into. The three of us chose orthopedic surgery, which is the practice of specializing in bones and joints, muscle sprains. And so we chose a profession that's 5 years of training, and in that process learn about how to take care of total joints, as mentioned, sprains, strains, spine care. And then the three of us all chose fellowships or one-year specialties after our training. Mine specifically was sports medicine.
Thank you. Dr. Kuzel, your fellowship was in upper extremity work, is that correct?
That's correct. Just want to say thanks for having me, Ray. So I did undergraduate at the University of Minnesota, medical school and residency there. And then I did an extra year of training in Milwaukee for upper extremity surgery. And the easiest way to describe that is I tell people shoulder to fingertips. And so I take care of a lot of shoulder problems, joint replacements, rotator cuff repairs, elbow problems, and then a lot of hand issues like carpal tunnel syndrome and fractures, hand fractures or injuries like that.
Thank you. Dr. Rust, as I recall, your fellowship was in sports medicine, kind of like Dr. Harms was. Can you tell us a little bit about the sports medicine fellowship and what you do?
Yeah, so sports medicine, there's really two types of sports medicine specialists. There's medical doctors who go into sports medicine, and they do the non-surgical treatment of sports problems. And then there's orthopedic surgeons like Dr. Harms and Dr. Kuzel and I, who can also go in and do an extra year of sports medicine training. And that primarily involves arthroscopic surgeries, which is where we use cameras to look inside of joints and repair torn ligaments, torn tendons like the rotator cuff, anterior cruciate ligament reconstructions, and primarily surgeries that involve the knee and the shoulder. So there's a little bit of overlap between us and Brad because we both treat shoulder problems, but sports medicine from an orthopedic standpoint is kind of specialty in arthroscopic surgeries.
Thank you. I appreciate that background here. Sam, tell me a little bit about what a sprain is. I'm going to start with those basic concepts.
Yeah. Just in general terms, a sprain is an injury to a ligament around a joint. The ligaments around the joint provide stability to the joint. Some of the most common joints that are sprained would be an ankle sprain. You can tear your ACL, which is basically a high-grade sprain. That's obviously in the knee. Also, there's sprains around the shoulder of the various ligaments that Brad takes care of. And they can come in various degrees. They can come in grade 1, 2, and 3. As they get more severe, your likelihood of requiring surgery or prolonged time in crutches or in a cast or immobilizer increases.
Brad, what's the difference between a sprain and a strain?
I usually think of strains as an injury to the muscle itself, whereas a sprain is more of a ligament that's a rounded joint, stabilizing a joint. And so a strain can occur in the muscle, the belly of the muscle, and it can be any muscle really in the body, but we see them certainly in the rotator cuff. We see a lot of strains in the back, certainly in the legs in athletes. And typically I think of strains as injuries that we almost always can treat without surgery, with rest, ice, compression, and sometimes over-the-counter pain medications.
The other thing I want to lay out is what's osteoarthritis? And I think, David, if you just give us a little bit on osteoarthritis as we go into this.
Yeah, so all of our joints, whether it's shoulder, knee, hip, ankle, all those joints move, and they move without friction with something called cartilage. And cartilage is smooth, it's shiny, and it's subject to injury. So you can have damage to that cartilage from a traumatic injury. You can have damage to that cartilage from a blood disease like rheumatoid arthritis. But the most common way that people damage their cartilage or have damage to their cartilage is with degenerative arthritis or osteoarthritis. So that's the most common reason why people get arthritis, and it's the most common reason why people need treatment for that arthritis, such as joint replacement surgery, injections, and it's there's not one specific cause for osteoarthritis. It probably involves a combination of lifestyle, so your diet, and unfortunately your parents, which you don't get to choose your parents. So if you get osteoarthritis, you might have to blame them.
Sam, on the lower joints, isn't weight a problem too?
It's a very large problem, yes. It's if you look at just the knee or the kneecap joint, the forces across the kneecap joint are 7 or 8 times your body weight. So if you can lose 50 pounds, you're essentially taking 350 pounds off that joint. So that's one of the things we look at when we talk about non-operative management of osteoarthritis, like Dave talked about, is weight loss and exercise, because it's such a huge factor as far as the forces across your hips, knees, and ankles.
I'm going to launch into the shoulder.
Sure.
And I'm going to start with you, Brad, and you guys jump into this one too a little bit. This is a 57-year-old gentleman from Wisconsin who's had, his question is, what are the long-term effects of steroid injections on chronic shoulder pain over 2 years, and ultimately, is he going to need a shoulder replacement? And I'll let you tee it up, and you guys can, with the sports medicine, jump into this too.
Yeah, so I think it's a great question. Cortisone injections or corticosteroid injections are it's a frequent treatment that we use for various shoulder conditions, whether it's a shoulder where we don't know exactly where the pain is coming from, or if somebody's got arthritis, or even if they have a rotator cuff tear. Sometimes we'll use cortisone injections in different situations. I usually tell my patients that I think that they are a very effective option that's pretty low risk but pretty high reward. I typically don't do more than 1 injection in any given space in the shoulder. So there's really 3 spaces in a normal shoulder. There's the main joint, there's the space above the rotator cuff, and then there's the space at the end of the collarbone between the clavicle and the acromion. And so sometimes—
Where's the collarbone?
The collarbone,
yeah,
the clavicle.
And the acromion. So it's right at the top.
Yeah, so it's right up there, yeah. And so sometimes if I have a complex patient and I'm trying to figure out where their pain is coming from, I'll use injections for both diagnostic and therapeutic reasons. But I think our academy that governs us, the American Academy of Orthopedic Surgeons, has in the last couple of years come out with some statements stating that we probably shouldn't be doing cortisone injections over and over and over again, because they can wear out the tissue of the joint, which in the shoulder could be the rotator cuff or the cartilage.
It's interesting, that's come back around. When I first trained, I'm old, that was 1 or 2 shots, that was all you got.
Correct.
Yeah, and I agree. I think a lot of people look at cortisone injections as a treatment plan, like I'm going to get these injections every so often. And I try to tell them that's not really the best thing to do. We want to You know, if we're going to use a cortisone injection, we should use it for a specific reason. And a lot of times that's a bridge to get you to an exercise program, to get you to some weight loss, to get you to ways to figure out how to improve the health of that joint. And if we can't do it, we shouldn't just rely on a cortisone injection over and over to try to solve the problem.
It's a very good question because it comes up every day in my office and in my practice is, well, can I get a cortisone injection? How long does it last? How many can I get a year? And we don't have the specifics on that. In my practice, I tell people usually no more than 3 injections per year. I don't know how you guys feel about that. But.
Well, then the next question with this, so they come in and how long does it take to regain function in a shoulder after surgery on a rotator cuff? This is a gentleman who wants to be able to throw his canoe over his shoulders and take off. So if you're not going to do injections, because after the injections you can do quite a bit, is the rotator cuff successful, and how does that go?
Correct. One of the things I just wanted to add too is I think all 3 of us agree, one of the reasons we went into orthopedic surgery is we like to identify a problem, and then ultimately there's a lot of definitive solutions that we can provide, and so instead of cortisone injections over and over again, sometimes there is a surgical solution that can take care of the problem, and then the patient doesn't need to take the cortisone shot anymore. They don't need to take over-the-counter or certainly stronger pain medications. Usually what I tell my people with the rotator cuff, I lean a little bit on science, and the science tells us that it takes about 24 to 26 weeks for the full bonding of the tissue down to the bone. And so certainly I let people do a lot of different activities before that. That's about 6 months. But heavy lifting away from the body and overhead, I try to get them to kind of hold off from doing that type of activity until 6 months after surgery. And I think, when we see patients, if we see them at 2 weeks, 6 weeks, 3 months, 6 months, that's the conversation that we have at each visit is, okay, here's what you can do, here's what you should avoid, to make sure that the investment of their time and certainly their finances in the surgery will pay off for them.
Yeah, I agree too. It's especially with rotator cuff surgery, because nowadays I think a lot of us are doing our rotator cuff repairs arthroscopically, which means through small incisions. The patients see their shoulder and they think, oh, these are just small incisions. I should be healed 3 months after surgery, doing everything that I want. But really it takes a full 6 to 8 months to recover from a rotator cuff repair. And if you educate the patients up front and let them know what to expect, then they're a lot happier, because when they get to 6 to 8 months, they know that that's the expected time to healing rather than being 3 months out.
That's an important point that Brad brought up about the 6 month to healing time for the rotator cuff. It's not a fast healing tissue. It has poor blood supply into the tendon. And if you try to push your limits early on, your risk of re-tear is very high. And as these guys know, going back and trying to fix it again is very difficult with much worse outcomes. Yeah,
the number one time that re-tears occur, they had a study that came out this year, is around 3 months. And it's because patients now are starting to feel better. Their shoulder actually feels better than it did before surgery, but that tissue still is not fully healed yet. And so that's, when patients come into clinic, I'm like, you're doing great, but you got to be careful. You just got to be careful here for the next 3 months, really let it heal.
How long do joint replacements in fingers and toes last? You guys got any feel for that?
In fingers and toes?
Yes.
It depends. I don't do surgery on the feet, so I don't know the literature on that. But in the hands, they can last for a very long period of time. But there have been a number of complications with joint replacement in the hands, more so than in the knees or the hip or the shoulder. And the main reason is there's not as much bone to work with, and there's not as much ligaments and soft tissue around the joints as a knee or a hip or shoulder.
And I think we talked earlier, our rheumatology friends are doing a much better job with rheumatoid arthritis. Let's move to the knee. So the knee, there's a lot of questions on knee replacements. Arthritis in the knee, what are you looking for, and when do you do a replacement? Anyone, well, go ahead and jump in.
It's one of the most common joints in the body to have arthritis, so it's something that I see every day in my office is arthritis in the knee. It can occur at a young age, it can occur at old age, and really when you look at arthritis, it's a spectrum, and it's a spectrum of how much it affects your quality of life. And really your decision to proceed with a surgical intervention like a knee replacement all depends on your quality of life, how much pain you're having, and whether or not you want to invest the time and to go forward with the surgery.
I think that's a great point that you're bringing up, Sam. And the key thing is that there are great interventions, but with any surgery, there's risk. There's always a risk of a complication. There's recovery, and that is variable for the different joints. And so, one of the things that I think we all do is we spend a lot of time talking with our patients about what the risks are, what the benefits are, what the recovery is. And I think sometimes patients want us to make the decision, this is the best option, but I think most of us strive, to provide the information like a teacher would or a guide, and then we really want the patient to make the decision for the surgery.
This question about the kneecap. What happens with the kneecap? Do you leave that or not?
Yeah, when we replace do a knee replacement, the kneecap is an integral part of how the knee functions, and most of the time we replace about half of the kneecap with a high-grade durable plastic. So it's the part of the kneecap that is underneath here that slides up and down in the groove at the end of the thigh bone, called the trochlea. And yeah, most of the time in a knee replacement, you replace that kneecap with a small piece of plastic about the size of a silver dollar.
This person is concerned. She's got a lot of pain in that area after surgery. Is there anything that she can do to alleviate that pain, or was there more surgery indicated?
Most of the time, if you have pain in the kneecap area, it's the first way to treat that is to check and see if you've gotten all your strength after surgery. It's amazing how, because the pain is gone so quickly, people forget that they have to continue doing their exercises for a full 6 months to a year to really get the best outcome. And pain in the front of the knee can definitely be a source or a sign that you haven't strengthened those muscles enough. So if that patient was coming to see me, I would check to make sure that they had good strength, and if they didn't, I would reinforce therapy. And
there's a lot of like Dave talked about, there's a lot of weakness that occurs in the quadricep muscle, and that's the muscle he's talking about. And around the time of surgery, you can develop a lot of bad habits or compensatory habits because of the pain before, during, or after surgery. And like he mentioned, getting that muscle strong is probably the best thing for that person.
Sam, as long as we're on the knee,
yeah.
A meniscus tear, what's the procedure? What do you do with something like that?
Meniscus tears come in all kind of varieties. And first, just to describe what the meniscus is between the two layers of cartilage within the knee, there's a shock-absorbing disc that helps spread the weight out across the joint, and that's called the meniscus. There's one on the inside and one on the outside of the knee. And that can get torn in a few different ways. It can get torn in a sports event. When you tear another ligament, you can get a rather large meniscus tear that can cause locking in your knee. If you're a middle-aged or older person, you can get some just wear and tear, kind of an early form of arthritis that can tear the meniscus. That can also cause swelling and mechanical symptoms. In the younger person, we try to repair them as much as possible because it's important for the long-term viability of your knee and preventing arthritis. Typically in the middle-aged, older person where it's more of a degenerative or arthritic type tear, and if they have mechanical symptoms, you can start with kind of 3 options that I tell my patients. You can watch it and take anti-inflammatory medications. We can try cortisone injection like we talked about before, or if those things fail, then go ahead with a surgical procedure where we use arthroscopic instruments like Dave mentioned before and typically just trim out that torn piece of meniscus.
Brad, there's a couple questions. When can you kneel on a total knee, after total knee? I know it's not in your area, you're up above, but.
Yeah, I think from listening to patients, I know a lot of patients don't really like kneeling after having a knee replacement, and I think that's probably something good to talk about before surgery. You guys probably have more of a feel for that than I do.
Well, first of all, you should make sure it's your knee, because if you're kneeling on somebody else's total knee, you're probably going to get hit. So, but yeah, I think I agree with Brad. It can be unpredictable whether people are really comfortable kneeling. From a mechanical standpoint, you're not going to do damage to the knee replacement by kneeling on it. It's really just a matter of whether or not you have comfort. And typically that's right where your incision is. That's right where a lot of the operating is done. So there's scar tissue there. And so I tell patients, you know, if you can use a stool or a bench to do your gardening, or find ways, if you're working in the shop, that you can take pressure off of that area, or even wear knee pads, just like people who install carpet or tile. I say go to Menards or go to Ace Hardware and get some knee pads and use those, and that actually can be an effective way to combat that discomfort.
IT bands. Do you fix them? Do you operating on them? 5 months of it stabbing. What do you do? You guys are the sports medicine guys.
Yeah, that's a difficult problem. I'm assuming that person's a runner probably training for a race, and it's a very difficult problem. Typically, you try non-operative treatment, including a lot of physical therapy, a lot of soft tissue massage, deep massage, and foam rolling, just rolling up and down the side of that IT band on the side of your leg. You can also try some injections, and there is a surgery you can do. It's just not performed very often because it's not all that successful, I would say.
So you'd like to hold back from that?
As much as possible. Typically just to add to that, it's usually a weakness in another muscle. So working a lot on hip and core, abdominal strength really helps that problem.
Brad, shoulder replacement.
Sure.
It had to come up.
Good.
What types of procedures are done for shoulder replacement? So we're back up in your area.
Yeah, so there's different kinds of arthritis in the shoulder. The shoulder's one of the reasons I'm drawn to the shoulder is it's a really interesting joint. And so there's standard arthritis, osteoarthritis, but then sometimes people can get a specific kind of arthritis from having really bad rotator cuff tears. The wear patterns are different, the arthritis is different, and they learned a long time ago that if you do a standard shoulder replacement on those patients, they don't do well. And so they actually developed a reverse shoulder replacement, which again is used for people that have a rotator cuff injury. And they call it reverse because in a standard replacement they resurface the ball and they put a new plastic socket on the socket side, and that's a total shoulder replacement. In a reverse, they actually put the ball on the socket side, and then the socket is on where the ball was previously. And it utilizes the deltoid, this big muscle on the outside of the arm, to help raise the arm. And so people that have really bad rotator cuff tears, or what we call rotator cuff arthritis or arthropathy, sometimes they can't even lift their arm away from their side, and with this replacement they now can. Both kinds of shoulder replacement, a standard total shoulder replacement or a reverse, are very effective at eliminating pain. They have very high success rates and very high patient satisfaction results.
To all of you, trigger fingers. Is that something you guys do?
Take care of a lot of trigger fingers.
What do? You inject them, or do you fix them, or what?
Yeah, that's one place where we actually do really like cortisone injections, because typically it's caused by scar tissue buildup around one of the tendons that flexes the finger, and actually in that case we kind of want that tissue to weaken, because if we can weaken that scar tissue, it can break up that area where that tendon is catching, and oftentimes that's all it takes to get that trigger finger to go away.
For orthopedic problems, is swimming a good exercise?
I love swimming. I think it's probably one of the best things you can do, along with going for a daily walk. I tell a lot of my patients, get out, go for a walk every day. Try to go a couple miles if you can. Not only is it great exercise for your body, your aerobic metabolism, but just for your mind as well. But swimming is a great, if somebody can find a pool, I think it's a great activity, because it takes away a lot of the effects of gravity, especially on the lower extremity, the knee, and if somebody's got foot issues. But even with shoulders, it's just a really nice way to move.
the water itself provides some resistance, so you do get a fair amount of strengthening as well. Not only does it take away the buoyancy effects and take stress off the joints, you get some resistance training with that.
And good overall body exercise.
Yeah.
Excellent.
Yeah, one of the few exercises that really works. Your arms, your legs, your back, your neck, your shoulder, you know, almost every muscle in the body.
Especially a warm pool, it feels good. You know, if somebody's got a lot of joint pains or muscle pain, it's a nice treatment.
Gentlemen, thank you. This goes so fast. There are many, many questions that we didn't get to. I want to thank our panelists, Dr. Samuel Harms, Dr. Bradley Kuzel, and Dr. David Rust, and our medical student volunteers, Michael Borner, Samantha Gardine, and Laura Lotka. Please join Dr. Ruth Westra next week for a program on eye problems when our panelists will be Dr. Charlie Ahrens, Dr. Joseph Morehouse, and Dr. Kevin Tracy. Thank you very much for your questions and for watching. Good night.